Those are my disclosures. It should be very clear here that the opinions presented are mainly my experience, does not represent the company experience. So, I have this previous healthy male, 69 years old, with controlled hypertension, developed acute chest pain. And it was discovered intramural hematoma in the ascending aorta of 5 millimeters thickness, mostly restricted to the ascending aorta and minimally in the upper descending 2-3 millimeters thickness. So that was not let's say, a team decision. Was just one group decided to have an open surgery, a Dacron tube, a bifurcated graft to the nominate trunk and left carotid artery, in the deployment of adenograph in the ascending aorta. And 6 months later, he developed a type B aortic dissection with all visceral vessels from the false lumen except the left renal, and also a minimally infrarenal fenestration between the two lumens. So now I'd like to show you the image. That's his device, and then this is the large communication that I have more detailed, and then all the visceral vessels, as you can see here, celiac trunk, and SMA, and right renal, and only the left renal from the false lumen. So that's the situation. We have a bypass here, and we have a large communication here. All three vessels from this false lumen here. A small communication here. This is the left renal, and the small communication between the false lumen and the true lumen. So that's the communication in the infrarenal portion. And so we have some crucial question here. Would be able to advance a shift in the reimplanted arch vessels here? And could we find this small communication to advance the device and at least save 3 branches? So that was a very difficult decision, or we send for open surgery. So I give them a chance on endovascular technique, or ask my friends who have brilliant minds and brilliant surgical hands, Dr. Chiesa and Dr. Melisano, if we have, could we try endovascular? So, you know, first we have to break a paradigm, because usually people say you cannot advance a shift in that anastomosis. And then we have to put a straight device to close that large communication, and then a branch device in the false lumen. So that was the plan. So the first step was done. We could move the 12-frame shift through that anastomosis from the right side and advancing the descending aorta. So the second was how to get a device from here into here, and then from left renal, from the false lumen to that small communication, and find the left renal. Or we do just the 3 vessels and abandon the left kidney, or even do open. So that's, I think that is a case we could discuss for a long time, but I'm going to show what we did. But our plan was that to put a straight device from the through lumen to the false, and then a branch device, and then do the 3 branches through this small window we have between the lumens, and then try to find from that branch the left renal. So we also, to advance this, we like to use that, we call the device driven by the shift. We advance in the same way, the tip and the nose of the device, and move the whole thing together, that avoid your device to touch the wall, the aortic wall, and also other previous devices. And also facilitates to move the device in the right position. So we we find a way here, I think, yeah. We find a way here, so we could advance our wiring and get through and through from this small lumen. So we advanced the device with this maneuver we call the device driven by the shift. We have that previous device also already implanted. Then, as we planned, we did the celiac trunk, superior mesenteric artery, and also the right renal. And the question was now, as we have the 3 vessels done, what to do with this left renal. Consider the life, his life saved, and then let that go, or try to get it, or do that open. So many options. We said, well, we are here. Let's try from this small lumen to find that renal. But as you can see, it was very, very unfavorable for wiring and the shift. So what we did? So we did the snare ride maneuver. So we catheterized it, here is the right, but we did the left. Catheterized the right renal from below. We open a snare, advance a guide wire, and then hold the whole thing inside. So that keeps your wire fixed. Exactly what we done. So we come from below, and we catheterize the left renal. Then we advance the wire and advance the shift. So finally, we did also the left kidney through that small passage, and that's the final control. So I think we had his CT scan showing that. So as we discussed in this afternoon with Tara, you may use the false lumen as long as you can get all the vessels to your device. Now the true lumen is my device. So everything is thrombosed. So I think Professor Chiesa is trying to resist the endostorm, but looks like he'll stay with a Vino bike or a pizza bike, but this group is going to do all the endovascular procedures. Thank you.